Hey everybody, sorry I'm a minute late. I run on beach time here in California sometimes. Welcome, my name is Kate Miller. For those of you who don't know me, I am the resident therapist and education coordinator for HawkTalk. And I am so excited today because we have Dr. Feinberg here, who works at Palmer West and has expertise in a lot of different fields and can share with you many clinical pearls. Specifically, he'll be talking about the shoulder and some specific pathologies today. I'd like to formally introduce you, Dr. Feinberg. Say hello. He's also in California with me, which is nice. It was easier to schedule.
Hello.
Go ahead, introduce yourself. Let's hear something about you.
Okay. Yeah, so I've practiced as a chiropractor for 34 and a half years now. I'm a professor at the Palmer College of Chiropractic West, and I have a particular interest in sports injuries. I'm an advisor to the board of the American Chiropractic Association Sports Council. I like working at events where we may have injuries occurring, so we can help people in acute situations. I also like working with individuals to maximize performance. I like to say that every patient really is like an athlete, because what's everyone's goal is to reach ultimate maximal performance. Let's see. Sort of recently, I worked with the Valor Games. That was quite a lot of fun. These are disabled vets, and we take instruments with us and work with HawkTalk at that location. And I worked at the World Games in Colombia a few years back. So quite an interesting sort of experience. Had some interesting experiences with shoulders in particular, which kind of brought me to some of the things we'll be talking about today. I've used soft tissue therapies since I first began chiropractic, and even before that, I was a massage therapist. I think that's a very important part of musculoskeletal care. When I first learned about iStim, it was dramatic because I'd seen many different types of massage therapies, but this was different. This was dramatic, and taught for Grafton when I first learned it as Grafton technique. Taught for Grafton for a decade, I think about. And then some issues came up and started working with HawkTalk. We've been doing this for a few years now. I'm not even sure exactly how much. When I saw this, I realized this was brand new to us. And one of my first patients once said to me, "Oh, this is like spooning." And I kind of wrinkled my forehead and said, "Spooning's something different to me. I'm not sure what we're saying here." And of course, she was talking about Asian types of therapies. We have a lot of Asians.
I've never heard it called spooning.
Yeah, and so they use the back of a spoon, and for that kind of therapy, and especially the Asian soup spoons, so they're not too sharp. And, learned that this, of course, has been going on for hundreds, probably thousands of years in Asia, with gua sha and those kinds of therapies. But recognizing it is something special. Just for myself, I like to mountain bike, a favorite activity of mine. I like to swim, and one of my new loves over the last not quite year is something called a one wheel, which is kind of like a skateboard with one big wheel, and I'll show you a couple pictures of that. It's kind of a fun thing to do. I call it a proprioceptive training exercise, and I'd like to take it off my taxes, but I'm not really comfortable doing that. So
you might be able to if you can justify it. It's all about verbiage.
Everybody has told me that, but I don't go there. I'm not going to go there.
You just got to have a good tax guy.
Well, you know what they say, everything is tax deductible until you get out.
That's true. Very true. I want to remind our listeners, our watchers, our viewers, our attendees, that if you share this information about the webinar and your thoughts with a hashtag HawkTalkLive, we want to send you a shirt and a cool little gift for joining us and sharing. Also, stay till the end. We do a raffle after every webinar, so one lucky attendee gets a special prize, and we'll announce that afterwards as well. So I'd like to formally start the presentation. If you have any questions, I did remind you in the chat room, please ask as they come to mind, and I will grab those as time allows. So go for it. We're going to start the presentation, and thank you for joining us.
Okay, so we're up now. So this is our topic. We're going to talk about two primary causes of shoulder pain and disability: is instability and impingement syndrome. These things can happen simultaneously. It's not uncommon for that to occur. They can also happen independently. And so we're going to go through each one of these. And just to kind of start out, I thought I'd show you what a one wheel is. And so this is something that you balance on, and then as you move back and forth, it controls the movement of this motorized vehicle.
Oh, that's cool.
Sometimes I think it's a little crazy that I do this, but I call it a proprioceptive training exercise. So should probably have a helmet on. But
like dirt biking on a hill. Look at you.
Yeah, I know. And this is just the same thing, but this is my daughter here on a beach, and me with a fat tire following her. Okay, so let's get started. Talk about instability. And so, shoulder instability. And so want to kind of preface this by saying focus here is going to be the glenohumeral joint. Most therapists, chiropractors understand that when you're dealing with the shoulder, you also have to think about the shoulder girdle. And the function of the shoulder girdle is very integrated with the function of the glenohumeral joint and the shoulder girdle. And so we're not going to have time to do that today. And so I'm presuming that, you would always be checking function of the shoulder blade, and is it moving too much? Is it moving too little? Do you have to stabilize it? Do you have to stretch it? All those things may be appropriate to work with to get best glenohumeral function, but didn't want to focus on that particularly today. So dislocations are an obvious kind of shoulder instability. They require a procedure called a reduction in order to create normal juxtaposition for the shoulder. There are some risks involved in this, and you make sure you know how to do this safely if you're going to be performing these things. Make sure it's within your scope of practice if you're going to be performing these things. And there's another kind of condition called a subluxation. Now, this is different than what a chiropractic term subluxation means. This is just instability, where the shoulder pops out a little bit and then pops back in. And patients, when they give us a history and they tell us what things feel like, a lot of times what they're saying isn't really accurate with what's happening. But it's been my experience when they say the shoulder felt like it popped out and popped back in, that they're frequently very accurate in that this is what's going on with their shoulder. And so, of course, when that happens, what we need to do is to test it to see, is it stable or not? Most commonly, the direction of instability is in an anterior direction. That's what we're going to spend our time talking about. Like they say, over 90% of instability happens in an anterior direction, but they can happen in posterior and inferior direction, in multiple directions. Some very interesting ways this can happen, and I have seen this. When I first read about it, I didn't believe it, but both electrical shock and seizures can cause posterior dislocations. And so be aware of those things, but that's not going to be our topic. Our topic is just going to be for the far more common situation, which is anterior dislocations. So if dislocation is present, if you are familiar enough to identify or to just simply observe the patient, you can tell at the shoulder itself what's called a flat deltoid. There's a deformity that's present, and you kind of see a picture of that here. If some situations with very large muscles, it might not be as easy to tell. There is an orthopedic test that you can use for this purpose, but in most cases you can just see the deformity, and it makes diagnosis quite easy. As far as subluxation goes, that's a different sort of situation, and so a medical condition, subluxation, is where it's unstable. And so now when the patient presents, they have normal juxtaposition. The shoulder looks normal. And so we have to do provocative tests to see, is this individual stable or not? And so the classic test is the apprehension test. And you see two demonstrations of the apprehension test on the lower left and lower middle images there, where basically what you're doing by externally rotating the humerus in the 90-degree abducted position, that tightens the anterior capsule, and it should hold the humerus properly juxtaposed to the glenoid. But when you create an P to A pressure on the humeral head, it starts to slip out, and the patients feel apprehension. Normally, patients should be able to be in this position, be completely relaxed and comfortable. And patients can tell this happening. It's a clear and obvious kind of problem. It can be a little confusing because with an apprehension test in that position when people have impingement syndrome that also is the area or the range of motion we call the critical zone. And so irritation, for instance, to rotator cuff tendon can also cause pain in this position. And that can be confused as a positive apprehension test. And so what we do is called a relocation or replacement test, where we basically put them in the same position. And so on the lower right side of this image here, you can see that while putting the arm in that same abducted, externally rotated position, you simply hold the humerus in a posterior direction. And when you find that they have greater range with less pain, that confirms that the apprehension test really is due to instability, and it's not a false positive test. Let's go back one more just to kind of clarify and see it even better, because I'm not sure if our images are covering that. The drawing also shows the replacement or relocation test. It shows it quite well. And so externally rotating. And just a little, clinical pearl. When you're doing this test, again, the positive finding is it feels better. Make sure that you don't put your hand right on the humeral head, right at the location, for instance, where an irritated biceps tendon might be. And then it'll hurt them. They'll report that it hurts, and you'll get a false finding from that. And so, you put your hand just like it shows there, just distal to the humeral head, on the shaft of the humerus with a broad contact. Of course, when instability is present, you can have labrum tears. And again, we're not going to go into that in a lot of detail, but you should know about that. Instability, whether it's from dislocation or subluxation, can cause humeral head compression fractures. That's called Hill-Sachs lesions. Those can occur. Both of these things, even when they're present, patients can recover with conservative care. There are times when they do need surgical care, but typically, we attempt conservative care first, and frequently you can find stability in that situation. It's important that patients control their activities until they are stable. And so one of the goals in treatment, and one of the few things that actually showed positive findings, it first happened at West Point. Physical therapists at West Point were the first ones to have a good response from conservative care. And that was, you work with them until they're apprehension free. You can do therapy until they're apprehension free. If they can't become apprehension free, you don't return them to risky activities where it's likely for them to dislocate or subluxate over and over and over. And every time that happens, it increases the likelihood of it happening again, and it also increases the likelihood of some rare complications that can occur and sometimes can be quite serious. This position also, and kind of demonstrated for us when we first learned about this process here, we do a biceps load test in this position, because the biceps tendon is one of the things that helps to stabilize the glenohumeral joint. And so that's kind of cool that happens and how that works. And so you test for slap lesions. And so if you have a positive apprehension test, if you put the patient in this apprehension position, 90 degrees abduction with external rotation, and then contract the biceps, contraction of the biceps should stabilize the shoulder and should feel good. And then that, again, confirms that you have an instability that's present. If contracting the biceps in that position causes pain, and so there's two different tests. So one of them you supinate, and the other one you flex the elbow, resisted in those situations. And what happens is if that increases pain, that's an indication of a slap lesion, and that gives us a different diagnosis and perhaps a different management. These things, of course, you can see with imaging if you do the right imaging.
Quick question, Doc. I love how there's so much overlap between some of the allied healthcare fields, such as occupational therapy, physical therapy, chiropractic. I mean, they're very different in a lot of ways, but there are similar orthopedic tests, for instance. And you went over a couple. Do you guys use for the instability, drawer test or like the load and shift that I think you might have touched upon? Would you say that there is a very similar testing procedure between the allied healthcare fields in your experience?
Yeah, absolutely. And we use those tests as well. Both of those tests as well. Continuing on. So I want to understand a little bit about, why and how the situation happens. There are more dislocations of the glenohumeral joint than all other joints in the body combined. It is inherently unstable, which allows us to have this extreme range of motion, but also puts us at risk. And so basically it's because of the congruence of the two bone surfaces. And so it's often described like a golf ball sitting on a tee. That's not a very stable situation. We have a huge humeral head and a pretty small glenoid. And so it's easy to kind of push it off the tee and dislocation occurs. So it helps to understand that. And so, the question is, how can we have stability when the joint congruence is so poor? I'm going to push the right button here. That's good. And this kind of shows, and what do they say? At any one time, only about 25% of the humeral head articular cartilage is contacting the glenoid. And so again, it's a huge ball and a small socket, and that's why we tend to dislocate or subluxate this joint. I know there's too many pictures here.
I love it. I'm a visual person, and I think for webinars such as this, there's a lot of talking, and so I can appreciate the images that you put on here.
Good. Okay, so if we, you can see here again, big ball, small socket, golf ball on a tee. If you look at the long head of the biceps here, it's kind of an interesting thing to note. If you have tension along the long head of the biceps, that will push the humerus toward the glenoid. And of course, the glenoid is surrounded by a soft, pliable, wet labrum. And when you push the humerus toward the glenoid like a suction cup, that creates stability. And it was surgeons noticed quite a few years ago that when people had rotator cuff tears that hadn't been repaired for a while, that tendons, the long biceps tendons got thicker. And some suggest, well, maybe the biceps tendon is still using some of the activity that the rotator cuff tendons do, which is to stabilize the shoulder. And so some individuals started using curls to help stabilize the shoulder, and sure enough, that showed that it has a benefit. So that's one of the things that we like to do, is to strengthen the biceps to help stabilize the shoulder. So just keep it in mind. And then again, we can see here the labrum and the long biceps tendon, as it runs intracapsular, kind of fascinating for a tendon, and that nice, smooth, huge humeral head that contacts the labrum. And of course, the glenoid contacts the glenoid, and the labrum itself is nice and soft and pliable. So when you squeeze the humerus against the glenoid, it helps to create stability, just like a suction cup. Another way, of course, we create stability is with the rotator cuff muscles. And so all the rotator cuff muscles have their individual functions, particular types of exercises to strengthen particular rotator cuff muscles. Also helps to change the tendons. Resisted exercise of those muscles changes tendon structure and tendon function. Tendon tenderness, tendon degeneration. So resisted exercise has a lot of benefit. But when all of the muscles, I guess you can see me here. I'm just going to try to show things here in the corner. Everybody can see this, right? My hand's doing this.
You're good.
Okay. So if you think about the rotator cuff muscles, when they act together, which is how they act in function, well, what do we have? We have two in the back. That would be the teres minor and infraspinatus. One goes over the top. That's the supraspinatus. Run around the front. That's the subscapularis. And when they all contract together, that pulls the humerus into the glenoid. Pull the humerus into the glenoid. That's how it creates that suction cup effect, which stabilizes the shoulder. I describe in my classes, when I exercise in the morning, I do the iron cross. I have rings in my house. So for about 10 or 15 minutes, just kind of hold it there. And everybody laughs because it's not really true, of course. But how can you do that? How can you do that activity and still not have the golf ball falling off the tee? And of course, the answer is that muscle contraction stabilizes the shoulder by pushing the humerus into the glenoid and creating that suction cup effect.
Well, I think in terms of shoulder injury too, there's innumerable risk factors to shoulder injury, and it's very patient specific, of course, every time. But I find, and you can tell me if you agree, I find that a lot of shoulder injuries are caused, whether it be directly or indirectly, by inactive or muscular dysfunction in the rotator cuff muscles, because they are very important for holding, like you said, that shoulder in place while the other force couples or more macromusculature around the shoulder work. So it's definitely not something to be ignored when you're talking about shoulder health and shoulder injury prevention.
Absolutely. And then also, when rotator cuff muscles, when you have a tendinopathy that's causing pain, or you have trigger points that are causing pain, those can refer to other areas, and sometimes to the deltoid. And so people go treat the deltoid when that might not be the source of the problem. The deltoid's a pretty strong, powerful muscle. Certainly, you can get injured, but much more commonly, the smaller ones get injured.
Right.
On top of that, the tendons have a particular risk. And it's different for different people, but we have this thing called a critical zone, a region of the tendon where there tends to be less blood flow, where you tend to have the problem of degeneration. It's where you tend to have tears. It is predictable. It's so predictable that you can actually build equipment so that when you're doing surgery, you end up right at the critical zone. At that site where there tends to be less blood flow. And just as another point of information, when we put our arm at the side, we're kind of squeezing those tendons. And when you squeeze those tendons, there's not as much blood flow to the tendon. And they did some arteriography to show this. It's sticking dye into the bloodstream and then taking x-rays. When you bring your arm to 90 degrees abduction passively, so not holding it up but resting it in that position, there's more blood flow that goes to the tendon. But what do we do when you have a shoulder disorder? We put you in a sling, so you keep your arm in a position where there's less blood flow. And, I say, well, you want to spend some time, maybe while you're watching TV, you put a bunch of pillows under your arm.
Right.
To hold your arm into that position to make sure you get blood flow. We take it further. When you're walking down the street, you need a girlfriend or boyfriend, husband or wife, with your arm in the right position. And, of course, if you don't have one, you can prescribe one.
If you don't have one, you could put your car, if you're not short like me, because if I put my hand on the car or my elbow on the car window, it's like this.
That's good, yes.
I'm a small fry, so it causes impingement.
I'm with you. Okay, continuing on. Pushing the right buttons. And again, this just shows how, the rotator cuff muscles wrap around the humeral head, and when they contract, they pull the humerus into the glenoid. Shows the location of the long head of the biceps, and again, force there helps to hold the humerus close to the glenoid as well. And of course, these muscles need to act in a very beautiful, orchestrated way to keep proper juxtaposition and stability, so that in different positions, different muscles act. And this is where therapy can help to train that in patients, in an organized, therapeutic, safe situation and in sports, so that you can then gradually move them to an activity where it may not be as safe, but they are more stable in that case. Again, lots of pictures. You can have instability because of weak rotator cuff muscles. Remember, this can happen not just because of lack of exercise or because of pain that causes me not to exercise. It can also be neurologic. So you can get nerve entrapments, and we have to certainly be aware of that and identify that when it's present. That can also come, by the way, from the neck. Of course, you get arthritis in the neck. And I had a patient, this is a number of years ago. And so when he was in high school and college, spearing in football was legal. Spearing in football is when you use a helmet as a weapon and slam it into your opponent. It was in the 60s that they made that activity illegal. That activity sometimes happens by accident, but doesn't happen on purpose. Well, my patient, they would train with the coach standing on the sled, and he'd be slamming his head into the sled. And he developed really severe arthritis in his neck. That led to atrophy of his rotator cuff muscles. The exercises just won't make him stronger. Ended up needing cervical surgery.
Yes, cervical issues tie so closely, as you can imagine, into shoulder.
Absolutely. And they can refer back and forth. Makes our job fun. Right. So again, the most common way that this happens is abduction and external rotation. And so it's similar to the position we do for the apprehension test. The shape of the glenohumeral joint capsule is such that in that position it gets tight. And so when you hold me passively in an abducted, externally rotated position, the tight anterior capsule keeps my humeral head in the proper position. If it tears sufficiently, then of course it allows for subluxation and dislocation. So this can be an acute trauma. This can happen from repetitive motion. And some people, have just ligamentous laxity, that can lead to these problems. And it's kind of a fascinating process when you think, what's the difference between instability and laxity? Laxity is a condition where it's not pathologic. It's something you're born with. It might develop with activity, but it's not a pathologic situation, but it increases the likelihood of developing instability. And so those individuals should have really strong shoulders, specifically rotator cuff and biceps. We see this in gymnasts a lot. Some gymnastic activities require ligamentous laxity of the shoulder. I actually taught hawk grips, iced him, to physical therapists for Cirque du Soleil. And he had an individual who had dislocated his shoulder, and they're doing rehab. And he said, what's normal range of motion and flexion is 180 degrees. And his athlete said, no, I need 270 degrees of flexion to do my job. Okay, that's, outrageous.
I don't think I've ever seen that.
Yeah. And yet, you have to throw everything you learned out of the book and, try and see what you can figure out in that situation. So that's one way, is abduction, external rotation. The classic way that happens in mountain biking, and I did do this to myself once, about 45 years ago. 25 years ago, is going over the handlebars. So you're riding down a steep hill, and your front wheel gets caught in a rut, and you go flying over the handlebars. You put your hand up to protect your head, which is important. Your head's important. But when the hand hits the ground, that causes abduction, external rotation. And so those occur. This is another way it can occur. It's a kind of cute little picture. Notice the banana peel. This happened to a friend of mine, by the way, mountain biking, quite a bit more skilled than I am. He loved to ride uphill doing a one-handed wheelie. And he lost control, let the front wheel get a little too high, put his hand back to catch himself, dislocated his shoulder.
I can tell you personally, this picture, I swear I have PTSD when I see this. This is exactly what happened to me. I was playing co-ed soccer in a league, and I did exactly this, and I had a shoulder injury. And actually, for those of you who can see, my ulna is no longer in the proper place. Hasn't been for years, but it's not fun, let me tell you. And I wish my shoulders were maybe a little bit stronger, and I could have avoided that.
Yeah. Okay, and there's other ways, of course, this can occur, just kind of showing you an example. Dislocated shoulder, you can see it. And by the way, there's different kinds of dislocations. So lower left image, you can see the different kinds of dislocations that can occur. But the bottom line is, when it's dislocated, you have to create proper juxtaposition first. And you got to make sure that it's safe to do that. So proper training is important. The diagnostic tool is what's called a flat deltoid. And so upper right, I think, shows it best, but these are all similar. And that is that the humeral head, because it moves inferior and medial, it doesn't push the deltoid out to the side as it normally does. And so, but from the acromion down, it just goes flat. And so frequently these things can be identified just by observation. X-rays show them as well, and that's just to show that. So what do you do for these individuals? Well, the first thing is reduction. You have to get proper positioning. This happened, and I hope I'm not telling too many stories to this process. In Colombia, when I was working at the World Games, and we were done. We were on our way to the closing ceremonies in a huge stadium, and it was going to be a lot of fun. And one of the assistants comes running up, help, we need some help, someone's hurt. Although he knew some English, this was in Colombia, he didn't know a lot of English, didn't know how to describe it to me, what was going on, so I went and checked it out. And his friend was holding his arm in the air, kind of like this, going, ah, ah, ah. And, the first thing to do is figure out what's wrong, and in that process, you got to have them relax. And if you're going to reduce a dislocation, very most important thing is the patient has to relax. And so we got that fixed up and headed to the closing ceremony. It's quite fun. So then what do you do? Well, you want to make sure they don't dislocate again. And so typically you're going to immobilize it with a sling and swath or a spica splint. There's controversy about which is best. of these two in the first 1 to 3 weeks, and then as soon as possible. And then again, this process started with physical therapists at Annapolis. Annapolis, they have a pretty rigorous resisted physical training, and it was the ladder crawl, where you're hanging on the ladder and you're swinging from one like a monkey, from one to the next. And when you swing, the one that got abducted and extremely rotated, that's the one that we dislocated. And for most of those individuals, when they dislocated their shoulders, it meant they couldn't complete the program. And they were able to increase people that were able to complete the program and recover from this condition from 10% to 75%. So a pretty significant difference. And so what did they do? Well, the primary thing they did was to strengthen the rotator cuff muscles. They started in isometric exercises while they're in the sling and swath or spica splint, as soon as they're able to, if pain allows them to, and then gradually build to maximally strengthening their rotator cuff muscles. We add to that the biceps. And so strong rotator cuff muscles and biceps help to hold the humerus in place. And so that could be all that you need. But at the same time, you also need to use those muscles when it's necessary to use those muscles. And that's where some of the soft tissue therapy and the hot grips can be quite helpful. And other kinds of exercise. This is where we use closed chain exercises now are considered the best ways to do proprioceptive training. And to clarify for anyone who's not sure, closed chain exercises are exercises where you're stabilizing yourself on the distal aspect of the extremity. So this would be with your hands in some way. And we'll show you some pictures of closed chain exercises. And then we would gradually work with them and move them into that apprehension position, but only if they're comfortable, not if they're feeling any sense of apprehension, so that we can work with that border once those muscles are strong to get them further and further and further into that abduction, external rotation position with stability. Now, when there's a little bit of pain in those situations, the use of iStim can help to decrease that pain so that they're able to do those exercises a little more effectively. Let's add to that. If you have trigger points, your muscles aren't going to be functioning properly. With the trigger points, hopefully they're going to work in a more appropriate kind of orchestration. Again, these muscles work in beautiful ways because as you move your shoulder in different positions, they have to contract with different intensities to create stability, especially in an unstable shoulder. And then the next thing is, of course, like we said, evaluate and treat the spine and the shoulder girdle as indicated. So we're just focusing on the glenohumeral joint here. But this is where the physical therapists in Annapolis were brilliant, which was, how long do you do it for? And the key here is until they're apprehension free. And so for some individuals, it's 60 days, 30 days. For some individuals, it's 6 months. But that becomes the key. And I tell my students this, because I've seen this in practice. I want them to learn the first day that this is our goal. And so the first day, and again, I'm talking about after dislocation, but it's also true with subluxation. I take the good arm and I do an apprehension test, and I say, you see, you can be relaxed. I bring it all the way back like this, and you're comfortable. And I say, okay, now let's do it on the bad arm. And of course, they scream. It's a positive test. Okay, we need to work with this until this test is the same as the other shoulder. And what happens very often is they just don't move their arm into that position. And if you don't move your arm in that position, you don't feel any instability. 2 weeks go by and come back. Thanks, doc. I'm feeling so great. Don't need to have any more care. I always like to keep a positive attitude. I'm so happy about that. Let's test it out. And then when we test it out, we frequently find, we're not quite ready yet because we have to have that positive test. But I remind them about that first day, because that's how they can understand that if they go back to activity before it's stable, they're putting themselves at greater risk. So closed chain exercises. And so the one on the right is the closed chain exercise. And when we do these, typically we start in positions that are more comfortable, and we gradually move them into further and further abducted, externally rotated positions. There's all kinds of fun ways of doing that. You can do this on a wood floor, linoleum floor, with a towel. And so I can have both hands on the towel and move the one hand into that abducted, externally rotated position. But the towel will prevent it from going too far so I don't fall and then dislocate my shoulder again. So it's a form of protection in that
Spider-Man push-ups.
Exactly. The monster crawl. I mean, there's all kinds of ways of doing that, that are valuable ways to work in this kind of situation. Come to my house and wash all my windows. And while you're doing that, move further and further into that.
Wax on, wax off.
Exactly.
Karate Kid, anybody?
Come to my office and clean all my tables and then pay me for the therapy, right? And again, there's many different types of closed chain exercises. This just shows more. And again, you can see with this, with the therapy ball, you can move it into different positions in different directions. And of course, during that time, get them to activate their rotator cuff muscles. Teach them to activate their rotator cuff muscles to help stabilize. Even, let's go back one. See how I know how to do this. You can even have them do, external rotation, internal rotation in that position. Again, I've had shoulder problems myself. One of the reasons I'm interested in these things. When I'm on my mountain bike, external rotation, internal rotation, isometrics can help to stabilize my shoulder. So I do utilize that.
Something that I've used with some of the shoulder patients and athletes that I've worked with is using like the resistance bands while people are up doing the push-ups. So they have that resistance to stay in that position, but at the same time doing those closed kinetic chain exercises with the band around their wrist or sometimes around their hands, depending on what their tolerance is in the individual. But I find that helps to engage a little bit of isometrics as well as isotonics kind of simultaneously in different muscle groups.
Absolutely. And it's the isometrics that stabilize the shoulder.
Yep.
And so that's a valuable tool.
Is that you?
No. I just grabbed the stuff you did. And so this is a closed chain exercise. Riding a bicycle on a cruiser with your arms up in the air, that's not really a closed chain exercise, but he's balancing to some degree on the distal aspect of his upper extremities. And then, of course, moving your body in different positions, this becomes a great closed chain exercise. Try not to fall. And same kind of thing, different position. And again, this can help to stabilize the shoulder as long as you don't fall. So there's a balance there, between, am I going to do this and get hurt again? You don't want to be doing this activity until you're apprehension free.
That's my favorite
exercise. I don't really know. I just thought it was a cute picture.
You can mountain bike. I'll do that.
There you go.
So real quick, I just want to take a break I know that we are limited on time. We have about 20 minutes left and plenty of material to go over, but I want to open the floor up for a minute for just a couple questions. We do have a few that I've been either privately messaged or prepared. What are your favorite tools for any kind of diagnostics, and do you use them for diagnostics in regards to the HawkRips iStim plethora of tools?
The tools for diagnostics. Oh, that's kind of interesting. Well, I guess, all the tools are helpful because they can lead to sense of pain, the sense of the grittiness that can be an indicator, we think, of adhesions in the tissues. You can feel with the tools, you can actually feel the presence of a trigger point just like you can with your hands. I would say for the diagnostic, these are really my favorite tools. But as far as therapy goes, there are some significant things to think about, and these two. And so this is, what did we, 5 and 7?
The two multis, yes. So you'll forgive me. We have 5 and 7 right there, or 5 and 6. Excuse me, 5 and 6.
Okay, 5 and 6.
And then 8, of course, the scanner is what we typically
get to that in a second. So what I like about this in particular, and depending on the size of your patient, is that this can fit right on the humeral head. And so how the general approach to using these instruments is you go gradual to specific. This is a great way to work on the surface of the humeral head. And of course, and to describe a little bit more about rotator cuff muscles, remember the tendons don't just attach to the bone. The tendons actually blend in with the joint capsule. and become the same structure. So, the cuff is actually tendon and ligament, which is indistinguishable. When we say, Netter's, what is Netter's pictures of human anatomy? Someone once said he removed all the fascia, because we didn't think that fascia was important. But, that's not how things work, is what we've learned over the last several years.
Great.
And so, it's important to recognize that, muscles don't just attach specifically to a bony attachment, but they attach, in this case, actually to the ligamentous joint capsule. So these are very nice for that purpose. What I also like to work with is the biceps tendon. And again, this is you can get rotator cuff tendinopathies, and you can find those spots specifically, and you can work with them to help desensitize them, to help increase the strength of scar that develops in that area. And of course, when you have a tendinopathy, that's a degenerative tendon. That's what tears. What's the statistic? 98% of tendon tears happen in degenerative tendons. How do we strengthen those tendons? Well, there's some information, some studies are showing us that these instruments, soft tissue therapy with these instruments, can strengthen ligaments, at least in rats. We'd like to think they're in humans, but they don't let us dissect humans. So that's too bad. But, they're mammals, we're mammals, it's likely the same. And of course, resisted exercise is the other thing. Now, resisted exercise can be difficult when you have a tendinopathy because it hurts to do the resisted exercise. The pain there can be more because of the tendinopathy. What happens with these tendinopathies? You get new nociceptors. It's called neoneurogenesis. So these tendons become hyper-irritable. We want to desensitize that so that you can do these exercises. That's where these instruments can be quite helpful. Biceps and rotator cuff. Of course, when you're dealing with tendinopathies, especially as you start the program with the patient, you want to be careful not to be too aggressive because it can aggravate and inflame the tendon. So you have to kind of balance. It's part of the art of what we do. How much force and how much stress, and always determine how does the patient respond to the therapy before you increase the tension, increase the stresses in these individuals, and always have them doing exercises so that they get more organized scar. We change the shape of the scar. The 8, this is Hopkins 8, right? The 8 works very nice also with biceps tendons. So biceps tendons are quite fascinating. They move 6 centimeters. That's more than 2 inches as you go through the range of flexion and extension, or internal and external rotation. That sliding function presumably gets limited when you have tendinopathies, which can shorten tendons, and when you have adhesions that can form, between the tendon and the tenosynovial sheath, maybe between the sheath and the bicipital groove. And so what I like to do as part of the therapy is, I like to heat it first. You can heat with exercise. I also use ultrasound to heat the tissues, and then get right between the groove and the tendon. So I'm not grinding right on the tendon with a lot of force. I'm getting right between the tendon and the groove and wiggling it, swiveling it back and forth to help create that movement. And I do that along with internal and external rotation, so I can stretch adhesions, which is probably what we do. When we increase range of motion, studies have showed that we increase range of motion. It's more likely that we stretch adhesions than we tear adhesions in these kind of situations. And I found that to be helpful as well. So those are the primary ones that I use for instability. I'm
going to add one. Oh, yeah, for instability for sure.
Well, and more, if I can just add one more thing. Yes, absolutely. Is, one of the wonderful things about this one is that you can have a broad contact or you can have a small contact. So you have a lot of different options there. And certainly, when treating trigger points in rotator cuff muscles, very valuable to work with this instrument there. And then, of course, other instruments. And so the one that you're pointing to, or the other one that we used to call a tongue depressor, can be used to get into the subscapularis. That's the one. What number is that? You don't know.
9.
9, thank you. You can actually get into the subscapularis. And, subscapularis is very important when you think about anterior instability, because the anterior instability involves frequently, now it could just be laxity, but frequently injury to the anterior aspect of the joint capsule. What blends in with the anterior aspect of the joint capsule is the subscapularis. And again, it's the same thing. The tendon and the ligament become one structure distally. And so, by putting the arm into that abducted and externally rotated position, I can get right in here. And then what I like to do as I'm working right into these tissues on the anterior aspect of the humeral head, I don't know if you can tell quite what I'm doing, but I'm trying here. Then what I'll do is I'll move them into that apprehension position until they feel some instability. And then, okay, that's the area I want to work with. I don't want them to feel instability. I want them to feel stable. So I back off a little bit. And then while I'm treating them right on the subscapularis, I have them doing isometric resisted exercises, against my resistance. So rhythmic stabilization. So I'll say things like, don't let me move you, and I'll do resisted external and internal rotation. And initially, they know what's coming. I just have them internally and externally rotating. And of course, while they're doing that, I'm confirming that they're not feeling unstable. They feel stable in that situation. And then we can have them work the biceps. Again, you can do a biceps load exercise in those situations. And what I find is that as you work with them, you can gradually get them into further and further abducting external rotation. And of course, our whole goal is to attain an apprehension-free situation. We have apprehension-free situation. We go, woohoo! That's our goal, and you're ready to go back to your activity.
We are amazingly, unfortunately, running out of time. I don't know how much we're actually going to be able to get into impingement, but I just want to add one more thing real quick about the tools before we try to get maybe 7 to 10 minutes in for shoulder impingement. And I can forward all questions to you afterwards as well if we don't have time to do an open Q&A. Is the HG4 is one of my favorites to actually get into a lot of the crevices. The shoulder is one of the, I think, most complex joints in the entire body. It has several components that go cervical, thoracic, the shoulder itself, and it's probably the bane of my existence. Shoulder's not my specialty. But HG4, I find you can get into supraspinatus underneath the acromion very, very easily with this part right here. I know I have tiny fingers. I mean, to me, they look like fat little fingers, but tiny in comparison to most. And even it's hard for me to get into some of the crevices in even the thinnest individuals. So I never replace my hands. I don't want anybody to think that these tools are supposed to. They're like any other clinician's tool, like a stethoscope, or it enhances the skills that you already have. And so this one is very useful for even getting into some of the subscap. You can use this end. It's very similar to the tongue depressor, or this end for hooking underneath acromion and working towards that supraspinatus. Let's see. So I'm going to let you kind of touch base on whatever you'd like to touch base on for impingement syndrome. Again, we are unfortunately running out of time. I'd love to have you back for a second webinar. But
are there questions that people have? Do you have like a list of questions that people have there? Because what might be more appropriate is maybe to save this for another time.
I agree. And I would love to have you back because I think that this has been a very successful webinar, and I wish that we did have more time, but we unfortunately don't. Some of the questions that I've been given are, can you demonstrate, can we maybe remove the slideshow, and can you demonstrate, whether it be with a few words, with the tools? We have some questions on any specific techniques, and this isn't an educational session in terms of giving you the proper 100% skills for using these tools, but they're wondering if you can give them any insight on treatment to the shoulder with the tools and with the slideshow down.
Okay, so first thing I need to know is how to stop slideshow presentation. That's probably how I do that.
Hey guys, we're big again. How are you?
Okay, that's cool. Well, yeah, it's kind of hard for me to demonstrate without having shoulder. And actually, just to kind of go back a step, you mentioned the shoulder is the bane of your existence. I like that. It is for everybody. Shoulders are challenging, and some of these things don't recover without surgery. And so, it's important for everyone to recognize that, and so, our goal is to give the patients the best chance to recover without surgery. If that's their option. It's always their option, of course, in those situations. For instability, well, again, I think I kind of described it, but for instability in particular, and let's see if I can maybe do some stuff on myself in this situation. And again, want us all to be clear here, we're specifically talking about anterior instability. You can get instability in other directions as well, but we're just talking about anterior instability. I think the key, and I don't want to miss other things. And so, it's really important, to treat all the muscles in the shoulder, all the areas in the shoulder, and specifically, most importantly, I think, are the rotator cuff muscles. And so we have the rotator cuff muscles that are easy to get to, so we can kind of start with those, and that's infraspinatus and teres minor back here. So that if you show me how you do that to yourself, you kind of can. And you can get right in there. There's actually nerve entrapments that can happen in here that I've seen recover quite well from some I-stim therapies. And whenever, by the way, you're working with a nerve entrapment, here's the rule. We don't want to irritate the nerve. Nerves are the most sensitive structures in the body. And, we learned this when it came to nerve gliding exercises. Before we had nerve gliding exercises, we tried to stretch the nerves. Very good. But stretching the nerves aggravated the nerves. They're the most sensitive structures in the body, and so that didn't work. So the nerve gliding, what a brilliant thing. I wish I would have come up with that. And so when you're working in an area where there might be a nerve entrapment, the general rule, and that's where specificity comes in, and that's the beauty of these instruments, is that we have such a specific contact. I can't do that with my hands. And so I can move, 5 millimeters to the left, 5 millimeters to the right. It's not a hard thing to do. But the most sensitive way to know, am I aggravating your nerve when I'm doing this? Because I want to be right next to the nerve. I don't want to be right on the nerve, is the patient's experience. And so I'll ask questions like, tell me if you feel anything shooting down the hands. I do this, by the way, when we're working in here, because your brachial plexus is coming through here. Tell me if you feel anything shooting in your hands. You don't typically have that happening, but I want to know. And sometimes, you're right on it, doc. And I'll say, great. And then I'll move a little bit left, a little bit right, because I don't want to be right on it. I want to be right next to it. It's the key with that kind of situation. But I think most important is working right on the rotator cuff muscles. And so there are things we can talk about with that. So infraspinatus and teres minor, pretty easy to get to, and it's too hard. I actually have to upload again, so I can't do that. So if we think of my infraspinous fossa, is like this, right? And so right here is my glenoid. So we have kind of an idea here. There are typical areas where trigger points tend to occur. So right underneath the spine of the scapula, just inferior to it, the inferior angle, and out by the musculotendinous junction. Those are the primary areas that I look at. Teres minor along the lateral side of the scapula, anywhere along there. And of course, I look for tender points. I look for areas where I can feel the roughness that we feel when we're using these instruments to work those in. Supraspinatus. Say it again?
The stucco. Have you ever had stucco walls? That's what it reminds me of.
Stucco. I thought you were talking about a professor. Okay, so supraspinatus can be a little tricky, and so one of the problems with the supraspinatus is that I'm with you on that, is the critical zone is right underneath the acromion, and so, and of course, that's where I want to treat, right? I want to evaluate that. And so, to test it, there's an orthopedic test where you actually put the hand on the hip. I don't know if you can tell what I'm doing. I'm trying to look at the thing here, right? So what am I doing here? I'm extending my humerus. And when you extend the humerus, you bring the critical zone of the supraspinatus anterior to the acromion, and then you can palpate it. And so I do this, with my students. We go like this, and it's best to be passive. So you have the patient with a hand on the hip, is how it's described typically. I find it much easier simply to have a patient supine with the arm hanging off the table. But you extend the humerus, that gives you exposure to the critical zone of the supraspinatus. Then you touch it. And when it's a little bit sore, that's called a tendinopathy. And when they scream, that's called bursitis. And so I'd say, okay, you just learned differential diagnosis. Okay, that's kind of the difference there. And of course, those are very related, and that's all part of impingement syndrome kind of stuff. So now that you really want to get right on that spot, that's where the smaller instruments can be quite helpful. This is also where it's important to be careful not to overdo it. Because you have a supraspinatus tendinopathy and you dig deep into that area, your patient's not going to come back. Is the bottom line, because it's going to be too painful. So it's really important, I think, for those kind of situations to recognize that this is something that's going to take time. It's not going to happen in one visit. And it's important for them to be doing their exercises in those areas. And, supraspinatus, when it comes to the tendons that have a critical zone, we don't all have a poor anastomosis. That's what causes the critical zone to occur. There's not enough blood supply right at that spot, especially with the arm down at the side. And so in those cases, in those situations, that's going to be quite tender. And so you have to give it time, for them to recover and of course, to be able to do their exercise. So that's the position I like to be in, when I'm actually working on the tendon of the supraspinatus. But then you also have, right where you were talking about, that little V area up in here, right, where the clavicle and the acromion come and attach. Thank you very much. Well, here's the problem. And of course, working right in that area is good. And also on the medial aspect of the supraspinatus, a lot of trigger points will develop there. And that's an important area to work. But I also want to get right at the critical zone. And so the process that I like to do is have the patient with a hand above the head in this position. Now, it needs to be relaxed, not holding it up in the air, because what's that do? That's going to tighten my upper traps, and it's going to prevent me from getting right into that thing. But I want them relaxed in this position. And then you can find, as you go as lateral as you can on the supraspinatus fossa, you can find that critical zone, and treat it. And then while treating it, you can go through a procedure where you bring it gradually behind the back and then stretch it in the opposite direction, and kind of connect the rest of the kinetic chain as part of that process as they stretch in those procedures. That's a nice little technique that I like to use. And when I do this, I will actually have it passive. I will be holding the arm and say, let your arm fall into my hand as I bring them down. I'm working right into that little corner there and then bringing it behind the back and going through a stretch. That making sense? Shoulder stuff.
We have maybe 1 minute.
Okay.
Last minute chance for clinical pearls here, folks. We have about 1 minute, and I am going to beg Dr. Feinberg to come on again to do Dr. Feinberg part 2, which hopefully he'll be able to do. He's a very busy man, and we'll be able to announce all that stuff if it works out. Also, if you have any further questions, you can always email me at any time, and I can forward any questions to him as well that maybe we did not get to touch upon. But last minute chance, if you have any sort of questions, we have literally about 1 minute before I have to end this. So I'm going to thank you all for your time before we do end this abruptly. And why don't we just have everybody ask questions via my email, and I'll forward them to you. That might just be a little bit easier in terms of answers. So they're going to reach out to me via email. So I appreciate you being here. Thank you so much. This webinar replay will be available in maybe 1 to 2 hours. It just depends on the processing time of Webinar Jam itself. It's out of our hands. So by this evening, the replay will be available, and we will also have it on our website. And Dr. Feinberg, I'll have a link especially for you that you can save for yourself forever, or you can share it with anybody. It costs nothing to be a part of it even afterwards. So we will have a special offer, which I just announced in the chat room for all of you guys who have stayed with us, and we'll pick the winner of the drawing shortly as well. So again, thank you all for coming, Doctor. Thank you so much. Stay tight. I'll talk to you in just 1 second.